It is my absolute honor and privilege to introduce Dr. Ilya Lipkin today. He is just a savant, truly. He is a hockey player. He is fluent in English and Russian and almost Italian. He loves to scuba dive and fish. He is a passionate father and husband, and he is also a competitive ballroom dancer. In all of his activities that he does, including as an educator as well, he finds time to also run a very successful practice, and he is a true MARPE master. So we can all give a warm welcome to Dr. Lipkin.
Thank you. Thank you. Thank you very much, and it's absolutely incredible. The audience, did not expect it to be this amazing this year, but it's just fantastic. Great to see you all. Yes, please join our WhatsApp group, and this is my number. If you ever need questions after this or clinical guidance, by all means. So let's talk about from diagnosis to treatment design. It's kind of fitting that I'm starting this talk because I'm going to talk about mostly how we get there. How do we get to expansion? How do we decide on the expansion? How airway aesthetics and scale anchorage have shaped today's orthodontic decisions, versus age-old extraction, non-extraction. These days, sometimes I go on some of these a website with groups like Facebook groups and ortho, and there's still extract, non-extract, and a lot of debate goes on. So hopefully I will be able to answer to that question to some degree. This is an article that I just saw recently in AGO, and the title of that article is essentially "When No Extraction Ever Becomes the Real Compromise," and they're talking about how we should never take. We should when people say that I never take the teeth out, it comes at a price of poor aesthetics, perio, poor function, and so on. They really do a job of defending extractions, and they start with the patient coming in that they saw a few months prior to this, and they recommended extractions. And now the patient comes back, teeth are sticking out, or full Blymax protrusive, the roots compromised, stability compromised, the cortical bone blown away, and they kind of group every non-extraction orthodontist into that. They say that the social media is promoting non-extraction treatment and how extraction that's called airway friendly, but it comes at a cost, a hidden biological cost of ruining anatomy and physiology. They say the orthodontics is about space management. So essentially, you have my favorite quote: if we have 3 cars in a 2-car garage, and what they're saying is what drives orthodontic decision is a space management, and for them, the garage is fixed. If you try to fit the 3 cars in a 2-car garage, you're stretching the walls of the garage too thin, and it just creates a problem. They badmouth distalization. They talk that they say that if you distalize, you basically making sure to impact the wisdom teeth and creating a more complicated extractions. And basically saying that non-extraction ortho is a marketing gimmick, and how extraction is basically branded as an old school. And but is there any merit to that? I think problem is that the orthodontic decision is that's how they look at it. They look at the rigid structure, and they're just trying to fit the cars into the fixed garage, and they're not analyzing the garage from many other aspects. I remember when I started working, and I started working as a resident while going to ortho program, and I worked in 8 different practices. Sometimes moonlighting or 7 days a week. I was working somewhere. And majority of people I worked for, basically patient would come into the practice, and the orthodontist would flip the Panorax and say, the treatment plan, braces. And some go as far as doing something like this. Now, this orthodontist, I took over when he got fired after doing this for about 15 years. He would just put a straight piece of wire on a young child and just change colors for a couple of years, right? Or how about this for a space management? That patient on the right side, she's been in braces about 2.5 years, and actually 4.5 years, sorry. And I already took off that straight wire from her, and they did the unilateral extraction, and spaces closed on their own. Who needs orthodontics? Just pull the teeth out, let the patient walk. Things will straighten out on their own. That's a space management, right? There is a lot of also sometimes space mismanagement. These things, DNAs, ALFs, Vivos, all have these outrageous claims, and all made in to promote and basically in the name of airway and non-extraction. But reality, all they do is just blow the teeth out of the bone. And I get a lot of these second opinions, and case after case after case comes in with molars splayed out and periodontal blown. And these kind of mistreatments, I shall say, or space mismanagement, it really does give the validity to the people who wrote the article. So to do this right, we really need to do this properly. We need to have a goal that we need to set, and we need to have a treatment planning, because we need to know where we're going, because without a plan, our goal is just a wish. And I learned that early on from Dr. Ron Roth, who always had, for every case that he treated, there's always a treatment plan and a set of goals. But when he was in practice, his tools and his abilities were limited by that era technology. Today is different. We have new concepts. We have new ways to look at things. Ron Roth, as great as he was really still looking at the garage as a fixed structure sometimes. Today we have, I asked ChatGPT, what's the modern orthodontics uses? And that's what ChatGPT came up with, regardless of how inaccurate that is basically TADS, MARPEs, SFRT surgery, and orthodontic surgery. But whatever we use, we need to have a clear defined goals, like satisfaction of desires. We need to do what patient wants. We need to fix the smile. We need to make sure that the perio stays healthy. We need to have facial balance and aesthetics. We need to make sure that TMJ is healthy. We need to understand that concept, and we need to understand functional occlusion. And unlike Ron Roth time, we also now have airway health, and certain decisions that we do would also impact that. So we as orthodontists, if we're going to provide a service, especially the health service, right, we typically are health service, then like one of my friends used to say, he's just a tooth jockey. No, I think we're providing a health service. And if we do that, then our goals should be met. And if we can't meet one of them, and that's, which is really legitimate. Sometimes if patient doesn't want to do something, it's okay that you can't achieve perfect class 1, or it's okay that you can't improve something, as long as the patient knows that, and you could sleep well that you told them. So going back to this extraction, non-extraction dilemma, I think it's really kind of a misinterpretation. Crowding is not a symptom. Crowding it is a symptom. It's not a problem. Crowding is a symptom of something bigger, something's more global, and we need to realize that. So I'm going to show you a couple of my old cases when from 20 some years ago. This patient and where I did the extractions, and as I look back at it, I realized it's not the extractions that were the problem, it's misdiagnosis, because I didn't look at it the way I'm looking at it today. So this patient, very crowded, blacked out teeth, very narrow arches, right? If you look, her lower teeth are all tilted inward. We went ahead and did maximum anchorage. We did a NANS button, we did a TPA, and retracted it all, and closed all the spaces. All right. And go again, referencing that article where they said, oh, you don't want to distalize because you're going to impact the wisdom teeth. Well, how often does this happen when we do treat the case with the extractions, or treated, and wisdom teeth still had to come out? So their concept that, oh, if you distalize, you basically just paying paying Paul robbing Peter to pay Paul because you still need to extract. That's not really a right statement. So she looks very nice, and probably if I post this on one of my Facebook groups, yes, it's going to probably people will make some nice comments. But reality is, her smile is very narrow. Her lower molars tilted inward, and there are some functional problems with that as well. So it's impacting the airway, and not in a positive manner. But her teeth look okay. If we compare this to another patient like this one. Also, the garage was fixed. I didn't have a choice of making the garage any different. So the expansion 15 plus 20 years ago was not really an option on already late post-pubertal teenager. And we had to extract, and that's what we did. But now, even her smile looked nice when she was done. You could still see how narrow that lower arch is, how narrow that upper arch is. And fast forward 10 years later, actually, she also had to take her wisdom teeth out. Look, when we try to set the arch into wider arc, despite of narrow maxilla, you end up having the teeth very close to the surface, very close, and potentially setting up the scenery for a future relapse. Look at the lower molar inclination. That's also problematic. And this is her picture 10 years later. Very, very flat in the front. And if you just visualize and picture her getting older, this is going to be somewhat of an issue for her, and it's already starting on some recession. So yes, did that, guilty. And now we're looking back, and we're trying to. Sometimes we get a chance to fix it. There are other people who will have different claims. So this patient had gone to other orthodontists, and she was told that she needs to have teeth extracted. And I suggested that she gets MARPE, and we could use MARPE as an anchor to gain the space. And she went. And she first agreed, and then we put the MARPE in, and then she called me the next day, and she said, "Oh, I can't. I think I'm doing the wrong thing. I can't let my child to go through this," and she forced me to take it out. And then she left. And then after a few weeks or a couple of months, she came back to the practice and said that she went everywhere else, and everyone else, some people who either did suggested extractions, or they suggested that they could just expand dentally with Invisalign. And if since already did partial payment, can she just continue with me, and can I do this with Invisalign? So I said, you know what, if not, why not? Maybe I'll do a decent job at it. Let's try, because people claim that Invisalign distalizes. Invisalign does this, and this. Let's try to move things around. So here we go. This was the plan. We set it up and started distalizing the teeth, opening space for the canines, uprighting the incisors. Essentially, according to this plan, we distalized about 5 millimeters. And this is, and I'm looking at this, and okay, maybe they are telling the truth. Maybe Invisalign can distalize. You get a space mesial to the molars, but I don't think that's being the truth if you really analyze it. So we go through this. We finish the treatment. I actually don't have a finished pictures for her, but here we made the space for the canines. And this is where she was at the last time we took the images. So in the middle, that's where she started. That looks like a fairly decent looking arch. We gained space. And a profile looks pretty decent, a little bit fuller than where she started, but that's not so bad. But according to the plan, we distalized 5 millimeters. But if you look at this, you could clearly see that her front teeth are just being pushed forward. And if you compare the Ceph, you could clearly see that we just created a little bit of a bimax protrusion. If you look at the cone beam and measure how much distalization actually happened, about 1.5 millimeters. So all that space that we regained just went forward. Basically, just blew the things out of the bone. And if you look at the cone beam reconstruction, this is exactly what you get. This is a very sobering look, because I know that 10 years from now, she'll be in some periodontist's office trying to fix this. So in retrospect, should have just left it alone. So let's start and see how we can use the plan and how can we direct our treatment planning so we don't end up in these kind of situations. Very simple. We essentially create a very simple systematic approach. We have problems. We go through this everything that we see in this patient records. Then we create solutions list, and as we go through the solutions list, we list the tools that can help us to address the solutions. For example, we'll start looking at a smile. We can check if there is a gummy smile. We could decide, okay, maybe it's a vertical problem, maybe it's a lip problem. If there is too much gum in the front and not enough in the back, okay, maybe it's a super eruption. If there is the other way, if the upper teeth in the right place, but there is a gummy smile in the back, well, maybe it's a skeletal problem, and maybe we need some intrusion. Maybe we need to change the occlusal plane. We continue looking at a smile and looking at the cants. Maybe there is more gum on one side. Is it a skeletal? Is it a dental? We need to make the solutions. And as we listing those problems, we could decide, do we extrude it? Do we intrude it? Do we use a TAS? Do we use the MARPE? We check the midline. Is it a skeletal midline? Is it a dental midline? And automatically decide on how we're going to fix it. We look at the shape of the teeth. Are the teeth undersized? Do we leave spaces? Do we involve restorative dentists? Do we need to use TADS, MARPE, bin sliders, and whatnot to create space? And so on and so on. Not going to spend too much time on it, but basically going problems, solutions, mechanics, and specific tools that we could fix the problem. And I'll show you the example of how this works. And then we go to the sagittal view after we analyze the front, and we decide on position of the chin, position of the maxilla. I heard Mike Gunson speak a couple of weeks ago, and he said when he's setting up his surgical cases, he sets them up like a denture case. Ortho is no different. We decide on our position of the front teeth should be. We decide how we're going to get it there. And is it a surgery? Is it dental? Is it how are we going to approach it? And obviously now in comparison to the how we used to do it, instead of having a fixed house, fixed garage, now we have an airway aspect in our orthodontic decision making. And sometimes we have to go back and look at our patients that we treated and maybe have a second look. Like this kid, I treated him when he was 20 some years ago, and we did the expansion. We gained some space. This is now his when he got all his permanent teeth, and then he's looking back at him, he still looks narrow. But to me, okay, it's just a mild crowding. The airway was not part of this conversation. I didn't look at his nose, even though I had a cone beam at that time. I didn't look at any structures. I just looked at the teeth. Put the braces on, straighten them out. Looks nice. Mom's happy, kid's happy. Goodbye, see you whenever. Then he comes back 15 years later as an adult. And yes, his teeth look still okay, but he's telling me that he can't breathe. And then he saw something online and he went from doctor to doctor, and he has an issue with his airway and sleep. And he does have a little bit of a deviated septum, but you could see how narrow his nasal passages are. Now, when I treated him, I left the upper molars flared out a little bit and the lower molars tilted in a little bit. This was misdiagnosis, clearly. He's got sleep issues. We go through nasal obstruction, symptom evaluation. Then he has dry mouth, shallow breathing, inconsistent sleep stats, impossible to breathe through his nose when he does something physically active. So now if we go back to his initial pictures, then we decide and how to. Sorry. So we decide on how to fix this. And if you look at it, you see it again. The lower molars are tilted in, the narrow smile. MARPE is a good choice here. So we we placed the MARPE, and just a few weeks into it, we got a lovely space. And this is what he says: breathing has improved substantially. Each breath is far more effortless. Deviated septum feels less like an act up, or when it does, at least less noticeable. I wear a Garmin during exercise, and I seem to maintain a far lower heart rate through exercise. Through breathing has improved. Not noticed sleep improvement, but I do wake up far less often due to mouth breathing. So this is an improvement. We've changed the diagnosis. We added the Airway into his diagnosis. I also want to, for those people who've never heard me before, want to talk about concept of bimaxillary constriction. I keep referring to lower teeth tilted in. This is not a new concept. Sometimes I would send the patient. I would recommend an expansion to a patient. Patient comes back and they say, "Oh, we saw the other orthodontist, and the orthodontist said that because our child does not have a crossbite, it doesn't need an expansion." But the crossbite is there, just hidden in the plain sight. You have narrow maxilla, and the lower molars are just tilted lingually. And then what ends up happening, if you just visualize how you take those molars, upright them, you do have a bilateral crossbite. And as a matter of fact, how Dr. McNamara proposed in his research and multiple publications, the concept of bimaxillary constriction and the treatment of it, that's how he did it. He just suggested upright the lower molars, create the crossbite, and then followed it up with an expansion. And this is how we approach these cases when we do look at the airway concerns. One might say, if you upright the molars, wouldn't you blow them through the cortical plate? Well, that's a great question. And I'll show you when, if you ever have Invisalign rendering and you took the cone beam and iTero together and put it in Invisalign software, if you try to upright the tooth, it'll look like you're blowing through the cortical plate, because the algorithm for Invisalign, it rotates that tooth around the root tip. And then if you do this, it will obviously blow it through the cortical plate. But reality is it's going to rotate around the point of resistance. So it's going to pretty much stays in place, just rotate. And if the tooth starts off tipped, you're actually going to have more room between the root and the cortical plate, even though it sounds a little counterintuitive. So many clinicians also point out that leveling curve of Wilson gives you more stability. So how do we decide? How much do we expand? Do we just throw in the expander and then see what happens? How do we match the upper to the lower? You want to stay away, because just because you can doesn't mean you should do something like this. This is clearly another space mismanagement. They just blew the roof of the garage. But to get started on this diagnostic path is really simple. You take this slide, and this can be done by your assistant, by the way. You don't even have to do this yourself, right? So let's say your assistant prepares your records for you to look at. What they could do is go to, this isn't done in PowerPoint, but you could do the same thing in a Keynote. Essentially, just take a drawing tool, outline the tooth, the structure of a tooth, and it creates a box and a shape of that tooth. Then you do the same thing, and you do the same thing to the upper one. Take that drawing tool again and just outline that molar. And I put 2 lines over here, and then I could, and then you'll see what 4. So I take that. If those lines were corrected properly, you would have also another shape that fills in with the color. But the point is, you take that one line and you put where the tooth is right now. Then you just take and tip it. And you could see, right, even if this is just an animation, this tooth did not blow through the cortical plate. Actually, you made some more room between the root, and that's what usually happens. And then you put the next line, and you see how much space between where the tooth was and where the tooth is going, you need to be. And it's about 3.5 millimeters. You put a little type note, or your assistant could type up a note. Okay, we need to upright the lower molars 3.5 millimeter per side. I mean, this is not exactly, it's an approximation. You could play with it. Then you essentially created a crossbite over here. So you put the green line, the yellow line where the tooth was, and this one where the tooth is going to. And then now you could just drop down to that ruler on the bottom of my cone beam, and it's telling me that we need to expand this, 6 millimeters per side. That means we need roughly about 12 millimeters of expansion. This is 7. Doesn't matter. You go to your either Invisalign software, or there's a tons of software, digital software that you could use, and you could just take those numbers and put them in. You could take that lower molar, upright it a couple of millimeters, create a crossbite like that picture on the top, and then move that upper molar out. It will show you in the displacement tab. It needs 5 millimeters of expansion. And then you could set it there. You could project and move the teeth and see how your case is going to work out and where you're going to need to end up. And how do we expand the lower? We could use removable appliances. We could use braces. We could use aligners. But if we're concerned about the peri issues, there is always Wilcodontics. I'm going to show you just an example of it because George, I think, is going to talk a lot about it tomorrow. But Wilcodontics, that's what started off by two brothers, Wilco, Tom Wilco and Bill Wilco. Tom was a periodontist and Bill is an orthodontist. And they put it into a nice system. It's essentially a corticotomy with bone grafting that changes physiology of how teeth move. When their system was accepted widely into perio world, they got scientific name of PAOO, which stands for Periodontally Accelerated Osteogenic Orthodontics. Periodontally, because it needs a periodontal surgery to activate to do the corticotomy. Accelerated because it changes physiology of a tooth movement. Now the teeth move a lot faster because the movement is not mediated by PDL. And osteogenic because it creates bone where it wasn't before, and it has to be done with the tooth movement. And Rick Robley later on coined a much nicer term, SFOT, which is surgically facilitated orthodontic treatment, which has a much nicer sound to it. But essentially, just a corticotomy, just like this, with the bone grafting, and it changes how the teeth move. While it looks drastic and dramatic, think about what happens to that patient if they already started with a recession, right? What happens in the future? They would still need this kind of grafting, but it might not be as predictable. I was honored by lecturing with Tom Wilco a few times, but this is how, for those who've never seen this before, this is how fast this goes. So I would have treated this girl very differently today. But back in 2006, she's a class 3 scale asymmetry. She's got an impacted canine. What are the choices? Where post-puberty expansion is very unlikely to happen, maybe just a dental expansion. We don't want to do harm. So let's try the Wilco. She's got that impacted canine. So the goal is, let's try to use corticotomy with the bone grafting and try to change the shape of the upper in order to create and fit all the teeth. Because because the reason I didn't want to just prepare her for surgery, because she wasn't sure, or the parents weren't sure if she's going for surgery, and certainly did not want to have an idea of just leaving her with an underbite and being socially awkward. So this is 2 days post-surgery. They did the Wilco just on the top, and they did the canine exposure at the same time. This is 2 weeks. You see patient every 2 weeks with SFRT. We opening space for the canine. This is 4 weeks. Space is greater. This is 6 weeks. Now the space is fully open. We start pulling on that canine. You could see the gold chain dangling down. Now we go through and 8 weeks. Space is fully open. The crossbite is fully jumped. Now we get to the 10 weeks. The tooth is in. And then now at 14 weeks, the tooth is almost in place. And a few more weeks of finishing, and this is how she looks just 20 weeks later. So I think this is incredible, right? But in Erie, Pennsylvania, where the Wilco brothers practice, they call it summer braces. It's because it's so fast. But to me, while the fastness of it is incredible, it's not the main goal. The main benefit here is that the phenotype of this patient, the bone is completely changed. She went from a very thin cortical bone. You could see dehiscence on number 10. And according to this tracing, all her front teeth just moved forward. Look at the bone after. No dehiscence, much more bone there around those teeth than was before. That's incredible. And then later on, I run into her about 7 years later, and where can a Russian meet the Irish, right? In the liquor store. So this Irish girl, Russian orthodontist, 7 years, no retention. I asked her to come to the office just to update the photos. And this is what she looks like. And I didn't get an x-ray, but it gives you an idea. So today I would have treated her completely differently. I would have used the MARPE. Might have still do SFOT, but it gives you an idea that it literally lets us to stretch the envelope. Another aspect, now that we dealt with transverse, just as important is the vertical. Very often, when I was a resident, we always used to have handheld models, and but handheld models, they provide little information. So if you really want to see where the vertical problem is, you need to ideally mount the case on articulator. And what can you get from it? If a patient looks like this, class 2 scale open bite, only functioning on the last molar, how do we know how we're going to fix that vertical? Well, very simple. We'll take that cast, cut the back molars off, and if the lower articulates forward and into a class 1, it's a vertical problem. You just need to figure out how you're going to get those back teeth out of the way. And if you have a handheld models, it's virtually impossible to diagnose this. And today you could certainly do this on some of the digital models, but the digital models, as well as those mounted models, they're not always accurate. But today there's a new tool. We could use AI to help us with that. And it's not expensive at all. So you could use software like Relu. You could merge CBCT and the STL file together and print this very, very accurate, literally exact replica of patient's head. Now you have a perfect articulation. There is no error in mounting here. And it's very inexpensive. It's about maybe $30. And this is printed on a $500 Anycubic printer that you could get online. Very cheap. And then what you could do is let's say this patient has a class 2 skeletal open bite. You just print 2 mandibles, one with the teeth, one with about the back teeth. And you could see that the mandible auto-rotated forward into almost class 1. So how are we going to fix this in real life? We're going to use intrusion or maybe surgery, TADS, to get the back teeth out of the way so the mandible comes forward. So now this is how we're going to solve our vertical problem. So we used to use a lot of a lot of articulators for some of those cases, but it's very time consuming and very labor intensive. But today is very simple, but my window still looks like a graveyard. But it's really practical tool because let's say this patient comes in and she's been in treatment with a dentist for a few years, and this is going to blow your mind. Okay, she came in with a constricted maxilla. She had a bilateral crossbite originally, and that's how they started. They use Alpha appliance to basically tip all her teeth out, okay, and then restore all of them vertically. Okay, $120,000 later, she can chew, she can function. Her mouth is completely, her muscles are tired. But if you look occlusally, it's nice class 1. It's not bad. But if you take that rendering and print and put with the joints where they really are, look at the amount of discrepancy. And the maxilla is still narrow. And look at the orientation of the teeth and the orientation of the crowns. If that's not malpractice, I don't know what is. And this is how you could decide how you're going to fix this. While it looks so dramatic on that middle screen on the top, well, if you get the back teeth out of the way, well, she rotates into a class 1. Maybe she's not so difficult after all. This is how you could practically address this. This patient has been in treatment for 2.5 years. She's got a big overjet, and she's told by an orthodontist that she needs an extractions. But is it really an extraction case, right? Because they're thinking space management, fixed garage. So cars sticking out of the garage, and now we need to park a couple of them out so we could park the rest of them in, right? But they're missing out the point. It's not about the extraction. This problem is not the garage. This problem is the 3D view of it, because she has a vertical problem. If you look at her lower face, she's struggling to close her lips together. Right. So we could change this with the expansion, and we have a perfect anchor on the palate. We could intrude the teeth, and by intruding that, we can have the lower jaw auto rotate forward, get the back teeth out of the way with that, and that's the progress. And you could vary the direction of the force, and voila! Here how she treated out. She's much nicer, wider smile, not so gummy. Look at her lower face, much more balanced. She we didn't have to park the car somewhere else. We just had to reshape the garage. Now this is how she looks post, and this is the profile. She's not struggling to close her lips, reduced vertical, and this is what it looks like on a Ceph. Look, if you look at the palatal plane, look at on before and after. Look how much intrusion that happened on these molars, and look at the airway. So what we've done here is we restructured this in a three-dimensional way instead of just parking the cars and thinking the garage is fixed. You can address that using the tools, and you could project that before you ever start touching that patient. So if you want to go step by step, this is another one. 39 years old, past treatment options, surgery or camouflage with extractions. And he did not want a surgery, and he's kind of suffering for many years because it was debilitating TMJ problems. He can't live without some sort of orthotic. You could see that on the Ceph. He basically, when his joints are in the right place, his bottom front teeth hit the top teeth, and that's where he's at. And he wants it fixed, and he's just trying to possibly avoid surgery if he can. So we start looking at the face. Look at the smile. He's got a little asymmetry. Something I learned also from Dr. Gunson's lecture a couple of weeks ago. Sometimes occlusal interferences may cause the the muscle tension. Like on this guy on the left side, it's more. It's pulling hard on that left side, but look at it; it's very narrow. You know, his nose is asymmetry. His midline is actually on. So we elevate this and evaluate this. We need to change the transverse clearly, and then we could. It's vertically. It's also slightly deficient. So we need to make it wider, potentially bring it forward. Can we do that? Let's take a look. So evaluating the smile, gingival display, increased in the back. We need to change the occlusal plane a little bit. Midline is on, nasal asymmetry, flat smile arc, gingival margins of the upper are a little bit shorter. Smile width, we got huge buccal corridors. So incisor position, gingival display, smile width, midline, alignment, occlusal plane, vertical. You can evaluate all that just by looking at one photo. Going back to the side view, sagittal, his incisors in the right place. Maybe can we move him a little bit forward? Can I afford a little proclination? Probably not so much. I think his upper is not too far from where they should be. It's the bottom, where the bottom jaw and the bottom teeth are much more forward. And we could decide, how do we do this? Is it skeletal? Is it surgery? So we look at all that, and then put the summary of all the problems that we have, the smile width, the alignment, the skeletal issues, and we could decide how we're going to address this. We clearly need to fix the transfers. If we fix the transfers, we could use protraction and bring it forward, probably a couple of millimeters. I see maybe some people doubting in the audience on the 39-year-old. Yes, you can. We need a width, we need a forward movement, and the lower incisors could afford a little bit proclination. And just like on that 3D rendering with the skeletal model, we could also evaluate where this is going to land. He's got a little bit of a skeletal asymmetry. Let's see how much he's going to need to expand. He's got 32 millimeter width. He's got an increased curve of Wilson. What we're going to do is we're just going to do exactly what I told you earlier. I'm just going to outline the tooth where it was before, where it needs to go, move that upper molar out of the crossbite. We need about 5 millimeters of expansion on each side, so about 10 millimeters in total. His nasal issues, breathing, not as bad as his TMJ, but sometimes patients will downplay those. It might not be affecting them as much, but when you fix the problem, they might be much more aware that, oh, I didn't know I had a problem until you fixed it. This guy doesn't have too many sleep problems either. His airway is fairly decent. So TMJ, these images are in place. So he's got a lot of muscle problems. The joints themselves are structurally sound, but the muscles are because he has to literally carry his mandible forward all day long. It's really really difficult. It's tiring. Try to carry a dumbbell all day long. It's challenging. A lot of muscle aches on his TMJ questionnaire. On a Panorex, just a little perio problems, nothing substantial. Upper arch, symmetrical. His lateral is a little bit small, so we need to, when we fix the transfers, we might need a little space for those laterals. Lower arch, a little misaligned. We want to look at the Malampati score. When we expand the palate, this will lift those tissues. He's not bad, but sometimes that could be another determinant factor to consider, let's say, expansions versus not. Now we need to space for the tongue, but his tongue tie is clearly normal. So, and when we look at the bite, he looks like a serious class 3. But if we do this regretfully, when I was preparing for this presentation, I asked, we gave the original skull to the patient, and I asked my assistant to print the new one, but she printed the latest model versus printing the original one. But it doesn't change anything. So basically, because he was biting on the front teeth, I had to print the skull without the front teeth. So now I don't have to figure out where this lower mandible is going to land. I by eliminating that anterior interference, I know exactly. And now I could see, okay, we just need maybe a millimeter of protrusion, a couple of millimeters of forward movement, upright to lower teeth, and we could treat him. So we could figure those all out before we ever start treatment. So we put all those problems, and solutions into the digital setup, do literally a run through, and create a treatment plan. And by the way, if you put this, let's say if you use Invisalign, you could do, as long as you don't approve the case, you don't get charged for it. So you could do this at no cost. So summary, we got deficient upper jaw, some asymmetry. We have lower class 3 skeletal, class 3 dental, symptoms of TMD, undersized laterals. We give them 2 treatment options. Obviously, surgeries first. Don't get me wrong. Whatever I could do orthodontically is still going to be a little bit of a camouflage. So surgery is still his ideal scenario. But if the surgery is not an option for whatever the reason, financial, I think we could get him pretty closely without significant compromise. We may need to use some additional TADs, possibly, piezo and so on, all the that kind of stuff with MARPE. And here's how this works. We're starting we're starting the expansion and protraction. See how quickly he's edge to edge just a couple of months into it. This is another, and this is another. So this is and this is what he looks like at the as of last week. So one of the things that you also could notice, there is a space mesial to the molars. When I have a MARPE in place, aside from using it for skeletal expansion, I use it also as an anchorage for protraction. Because the molars are fixed to the TADs, I could push all those front teeth forward and bring them together. So we leveled the curve of SPE. We're bringing everything forward. We're getting the roots aligned. And this is that bottom picture on the right side. That's his latest where we are. And this is just this is not him, but just for those who want to, let's say, to protract. Because when you start closing spaces in the front, you don't want to retract, right? Obviously. So you could use the MARPE and push things forward, use it as an anchor. So this is what he looks like. We got his maxilla a little bit forward. How much forward? This is how much. If you measure it from the nasal spine to the basian, it's probably forward about 2 millimeters. Not a lot, but just enough to get us where we need to go. Remember that outline where we did the projection for 5 millimeters? We've gone from the 31 to 41, 10 millimeter expansion on a 49-year-old. No SARPE or 3-piece maxilla could ever do that. And exactly what was planned out, exactly what we've got. And lastly, perio. we didn't get any worse than where he was. Ideally, if I would, he couldn't afford a Wilco, couldn't afford to go see George. But ideally, that's if he had the means, I think he could have benefited from doing the Wilcodontics. So this is what he looks like, and this is what he has to say about his experience.
Hello, my name is Francis Vogus. I'm a patient of Dr. Lipkin. I recently had the MARPE treatment. Before the treatment, I had an extreme overbite where I was unable to take pictures. I was grinding my teeth throughout the night. I was starting to lose the back of my teeth. I was unable to sleep throughout the night. I would get headaches. My jaw would start to lock. After the treatment, my appearance has totally changed. My face structure has changed. My cheekbones have changed. I'm able to breathe and I'm able to sleep throughout the night. I'm able to take pictures. I'm able to eat foods that I haven't wasn't able to eat because of the way my bite was. This procedure has totally changed my life. Thank you so much.
So we changed his life, we changed his structure, but we knew that was going to happen before we started. That's the point. It was an extraction, non-extraction debate. We changed the garage in 3-dimensional space. Now about those distallizations that we talked about earlier. How about this girl? And again, same scenario applies. We very narrow maxilla. Look at those molars collapse. There's no room for that tongue. We have, as one person referenced, we have a 5-foot tiger in a 3-foot cage, or again, same proverbial 3 cars in a 2-car garage. We need to restructure this garage. So we could put the MARPE in and use that as an anchor to distal drive the teeth. Now those teeth are actually going back because this is a skeletal anchorage. And this is where she is. And again, we're reshaping the garage. We're not pushing the cars out of it. Right? So this is what she looks like now. And look at her ceph. We didn't create bimaxillary protrusion. We didn't impact the wisdom teeth, right, so much because while it looks like dramatic change and it looks like dramatic distalization, it actually not as much as you might think. If you look at her, this is where the before and this is after. All the teeth are in place. Second molars are in place. And if you look at her perio and bone support, it's not we didn't push anything out of the bone, so we just restructured the garage and kept the cars in place without necessity of taking them out. So it's not about extraction and extraction. Extraction was the symptom. The problem was the garage was off, and we fixed the garage. We'll make it wider, and once we made it wider, we rearranged the cars. The amount of distalization was only about 3 millimeters on each side. But that between expansion and not much distalization, we had enough room to fit everything in without pulling the teeth out. Can we do that on an adult? Of course. Here, we're not going to argue that these wisdom teeth are not coming in. So those people who wrote that article, they that would matter, but very, very crowded. And just think about it. She's very, very narrow. She has she does have some fillers that will give her a lip support. But other than that, if they weren't there, that might have been a problem. She's not terribly, a little bit crowded on the bottom, but it's mostly collapsed from the sides in. And she's got completely blacked out canine. So if we take the wisdom teeth out, we could use that space. Those wisdom teeth are impacted and useless anyway. Right? Why do we need to take 4 more teeth out? So we put a MARPE in and we use something that's called bin slider for those who don't know it. It's basically a bar that has a locking mechanism. And then when you squeeze the spring and activate the mechanism, it will drive the molars back. And so we've expanded, and she didn't need a lot of expansion. Just because you put the, let's say, 14 millimeter screw in, it doesn't mean you need 14 millimeters of expansion. You need what your plan calls for. And then once you get distalized, you can continue using that MARPE as an anchor to get the rest of the teeth in. So when we got the molars back, now we're using that. We put a little power chain right here and just continue pushing things back, making space for everything. So now the tooth is in, and this is where we are at the current moment. She looks significantly better, much nicer aesthetically, getting close to the occlusal. And now we're going to start finishing it up. So on the ceph, You could see the front teeth didn't get pulled out of the bone. We didn't create bimaxillary protrusion by not taking the teeth out. Perio and root alignment is very nice, and everything is in place. And aesthetically, look how much nicer and wider that smile is, right, in comparison to where she started. If this was a 4 bicuspid extraction case, she would have left being narrow. And that would not have been a nice outcome. And now that we're ready to finish her up, we could take all those teeth and actually, now that we know where the bone is, we could try to guide it and try to make sure that the teeth are going into the bone and not staying out of it. And it goes on a case after case after case. A case like this, another severe class 3, another severe crowding, and he was told that he needs 6 teeth. He needs to have premolars out, and possibly I think they already took his wisdom teeth out. So now, can we fix him? Yes, he's got a huge transverse problem, huge front to back problem. And then if we try to pre-plan it, we do the measurements, we put it into a digital system like Invisalign or any kind of planning software, we could predict that this could be treated without a surgery, just using a MARPE and protraction. So here we are. We're going from here to here to here. You could see that we didn't create a bimax protrusion. And as a matter of fact, if you look at his Ceph, this is the upper teeth are staying at the same angle. What really happened here? Well, this happened. His whole midface, not just the maxilla, his whole midface came more forward. And this is what his bones looks like. We didn't create any perio problems. You could see the rendering, and the bone is there. And he went from a severe class 3, severe crowding, to this. And this is what his words were. In traditional orthodontists I met with, they said I need 4 to 6 teeth extracted and jaw surgery to correct my underbite and teeth crowding. I'm immensely grateful Dr. Lipkin helped me avoid all that. One unexpected side effect: before treatment, I used to occasionally wake up with a dry mouth, which I honestly thought was normal. Now I can't even remember the last time that happened. And the point is, this was all, there's no way to guess this, right? I can't just look at it and say, okay, I'm going to do this and hope I'm going to fix you. Right? If I go through the same list of checks and balances, and I know exactly how I can affect his garage, then I know I could fit all the cars. And lastly, this patient, she's been to 5 different orthodontists, and every one of them tells her, you know what, you look fine, and they're refusing to treat her. But let's analyze it. Look how narrow her smile is. She's not happy with the way she looks. And if you look at her molars tipped lingually, so but she has a vertical problem. But if I analyze this vertical problem, if I'm going to reduce that vertical, she's going to end up with the lower jaw coming more forward. She is a surgical case. I can't fix this orthodontically. I can't fix this with TADS and MARPE will only help me to widen the maxilla and to help me to upright the lower molars. And then that's what we've done. We did a MARPE. This was before the custom MARPEs. This was my own customization when I started using the MSCs and adding TADs to it. And this is right before the surgery. You already see that she's got a wider smile. And then she goes off to Mike Gunson, which creates a absolutely beautiful outcome, and fixes the airway, and then she looks absolutely stunning. Huh? Yeah. So thank you. So when we get this diagnostic flow, we need to go transverse first because it's the most undiagnosed. We need to consider MARPE, expansion, SFOT, skeletal versus dental, airway implications should be on a front page. And then we could decide on sagittal control, on TADs, distalizations, protraction, auto-rotation versus intrusion, vertical control, and possibly surgery. And with MARPE and the TADs, we don't just have the tools. We have really a full 3-dimensional control. So when we get to the goal-directed treatment, and we could really satisfy the desire, smile aesthetics, perio health through the SFOT, MARPE expansion, facial balance, TMJ health, functional occlusion, and if for some reason we can't accomplish one of these, let's say if the functional occlusion requires surgery or facial aesthetics requires surgery and patient doesn't want it, well, it's okay, as long as they know that's what their ideal outcome is. And in summary, crowding is just a symptom. Crowding is not a problem. When we have 3 cars in a 2-car garage, it's not about should we park the car somewhere else or should we try to fit them in the garage? We could remodel the garage. We're not choosing between extraction and extraction. We're really choosing how much work and how much control do we want to put into the case and come up with the outcome that patient will be happy with. A proper analysis in all 3D planes of space is really needed to accomplish the goal-directed treatment. Don't think fixed box. Don't think mesial distal. You have top and bottom, vertical, sagittal, and so on. And if all the goals are analyzed and everything is planned out before the treatment, then your goal is set, and you could accomplish it very, very well. And thank you, and may the expansion force be with you.